So imagine going into surgery, right? You're trying to fix this incredibly painful, restrictive anatomical fusion.
Right.
But then you wake up and find out that the actual cut of the surgeon's scalpel, like the surgery itself, is the exact biological trigger that tells your body to just, glue itself right back together.
Yeah, it's an incredible medical paradox.
It really is. Today, we are unpacking a paradox that basically turns the body's own healing mechanisms into a weapon.
Mm.
We're stepping into the world of chronic dermatological conditions.
Specifically those affecting the anogenital region, yeah.
Exactly. And the diagnostic landscape here is so complex,
Mm.
and the biological mechanics are just deeply counterintuitive.
And, I mean, the clinical reality is really compounded by the silence around it. People don't talk about it, which leads to a massive delay in getting actual answers.
Right. So for you, the curious learner who actually asked us to look into this today, we know you're looking for a clear, thorough synthesis of a topic that usually gets swept under the rug. You want the mechanics explained.
Which means we really have to bypass the superficial symptoms and look directly at human tissue remodeling.
So our mission for this custom-tailored deep dive is to tackle one very specific question. Does lichen sclerosus cause labial fusion?
And to answer that, we've pulled a massive stack of literature.
Oh yeah, we've got NHS clinical pathways,
Yeah.
national guidelines from BSHH, position statements from the BSSVD, and some truly mind-bending clinical case studies from the PMC archives. Okay, let's unpack this.
We can start by promising a definitive yes to that core question.
Yes, absolutely. But more importantly, we're going to explore the biological mechanics of how this fusion actually happens.
Right.
And the strange mystery of where it happens.
And of course, the delicate tightrope doctors have to walk to try and undo it.
Right. So before we can really map out how separate pieces of anatomy physically fuse together, we have to establish the pathology of lichen sclerosus itself, or LS.
Yeah, the literature universally defines LS as a chronic inflammatory skin dermatosis.
Which means what exactly for the patient?
Well, it presents almost exclusively in the anogenital area. You'll frequently see it described in a figure of 8 pattern, right? So it encompasses the vulva and extends down around the perianal region.
The visual markers in the BSSVD texts are, incredibly specific. They describe these pale, ivory white, crinkled patches of skin.
Yeah, they constantly use the term cigarette paper to describe the texture.
Cigarette paper, exactly. The skin gets profoundly fragile, and the hallmark symptom is this intense, relentless itch.
Which notoriously spikes at night.
Right, just completely devastating a patient's sleep architecture. And if we look at the demographics of who actually gets this, the data shows a bimodal distribution. There are 2 peak onset ages, prepubescent girls and postmenopausal women.
And what's key there is that both of those life stages represent states of naturally low circulating estrogen.
Right. But we should clarify, it's not caused by a lack of estrogen, is it?
No, not at all. Hormone replacement therapy does not cure LS, but that low estrogen environment just, appears to provide a highly favorable background for it to trigger.
Okay, got it. The guidelines also make a massive point to aggressively dispel the biggest misconception here. LS is not an infection.
Right, not at all.
It is not contagious in any capacity. The consensus points directly to an autoimmune etiology.
And that autoimmune mechanism is where the pathology really takes shape. So studies show that 60 to 80% of women with vulval LS produce autoantibodies that target a specific protein.
Extracellular matrix protein 1, right? ECM1.
Exactly, ECM1.
So if the immune system is actively hunting this structural protein, what is ECM1 actually doing for the skin in a healthy person?
So it's a crucial regulatory protein. It basically helps organize the collagen bundles in the dermis. It dictates how the skin's structural scaffolding is built and maintained.
Oh, wow.
Yeah, so when autoantibodies degrade ECM1, that collagen assembly process just becomes completely chaotic.
So the skin loses its structural integrity.
Exactly, which directly leads to that thinned out, crinkled cigarette paper appearance we talked about.
And about 1 in 4 patients with LS also have other autoimmune diseases, right? Like thyroid issues or vitiligo.
Yeah.
So it's a broader systemic issue.
Yeah, a loss of overall immune tolerance.
I mean, I like to think of the immune system in LS as like an overly aggressive, deeply confused bodyguard.
That's a good way to look at it.
Right. Its job is to protect the VIP, the skin. But instead of scanning for outside threats like viruses or bacteria, the bodyguard suddenly just turns around and starts attacking the structural framework of the VIP's house.
Causing massive collateral damage through chronic inflammation, yeah.
And that collateral damage answers the core question you, our listener, had about fusion. because this chronic inflammation doesn't just sit on the surface causing a rash.
No, it actively remodels the physical architecture of the vulva. The continuous degradation of that matrix leads to profound anatomical changes.
The BSHH guidelines detail this progression. The labia minora, the inner lips, they can shrink, resorb, or physically fuse to the labia majora.
Or, in a lot of cases, the left and right labia minora actually stick to each other across the midline, creating the structural bridge.
What's fascinating here is, wait, I want to use your phrase. What's fascinating here is the terminology used in older texts. You see the word resorption a lot, right?
Yes. What's fascinating here is that resorption implies the tissue has simply vanished or melted away.
Right.
But from a structural standpoint, the anatomy, like the clitoris or the labia minora, it isn't actually destroyed. It's just trapped.
Trapped? Wow.
Yeah, the original structures are buried underneath thick layers of rigid scar tissue.
The fusion of the clitoral hood is a prime example of this trapping effect.
Yeah.
The hood can adhere to and completely scar over the glands of the clitoris.
And the case studies highlight how this burial creates an environment where naturally sloughed dead skin cells and oils just get trapped underneath that scar plate.
Which eventually forms those incredibly painful pseudocysts.
Yeah.
And this scarring also frequently leads to introital narrowing, where the vaginal opening significantly tightens. But wait, I want to push back on the physical mechanics of this process because I think the jump from inflammation to fusion is where the logic gets a little murky.
How so?
Well, if the skin is just inflamed and the collagen is disorganized, how does it actually glue itself together? Because, inflammation usually implies swelling, redness, heat, not a biological adhesive.
Ah, okay. That is the pivotal transition in the disease process. Because the ECM1 protein is degraded, the skin loses its elasticity and becomes exquisitely fragile.
Okay.
So it's highly susceptible to microscopic splitting or tearing, which is clinically called fissuring.
From just basic stuff, right?
Exactly. A patient can experience fissuring from wiping with toilet paper, the friction of tight clothing, or sexual intercourse.
So the skin's structural integrity is so compromised that it literally just breaks under minimal physical stress.
Precisely. And when that tissue tears, the body initiates a standard wound healing cascade.
Enter the fibroblasts.
Right. Fibroblasts rush into the wound bed, depositing dense networks of fibrin and collagen to bridge the tear and create a scar.
Okay, that makes sense.
But here's the catch. Because the entire area is swimming in inflammatory cytokines, and because anatomical structures like the inner and outer labia rest naturally flush against one another.
Oh, I see where this is going.
Yeah, those fibroblasts don't just repair the single tear. They lay down collagen that inadvertently binds the adjacent inflamed mucosal surfaces together.
So as the body tries to heal a microscopic fissure on one side, the biological spackle it uses ends up adhering to the tissue resting right next to it.
Exactly. The repetitive cycle of the skin tearing, followed by this overzealous inflamed healing response, just progressively stitches the anatomy together.
It's basically a pathological healing loop.
The wound repair mechanism is co-opted by the inflammatory environment to permanently alter the physical geography of the tissue.
And if the tissue is literally altering its own geography, that leads us to a massive medical mystery we found buried in these sources.
The positional information mystery.
Right. Why does this confused healing loop primarily isolate itself to the anogenital region? To explain the why here of it all, we have to look at this mind-bending clinical case study from the PMC archives involving a pudendal thigh island flap.
Yeah, this case fundamentally challenges how dermatologists conceptualize autoimmune skin diseases.
So the case details a 66-year-old woman suffering from severe vulvar LS who unfortunately develops vulvar cancer. These surgeons excise the diseased tissue, and to reconstruct the area, they use this pudendal thigh island flap.
Which basically means taking a vascularized flap of healthy hair-bearing skin from her upper thigh and grafting it onto the surgical defect on her vulva.
And standard presentation dictates that LS almost never affects the hairy skin of the thigh, right?
Right. The thigh skin is inherently resistant to the disease process, and initially the graft takes beautifully. For months, the transferred thigh tissue remains perfectly healthy in its new location.
But then 8 years post-operation, the patient returns. And the previously immune thigh skin, which is now residing on the vulva, has been completely consumed by lichen sclerosus.
Meanwhile, the donor site on her leg, the exact place the skin was harvested from, remains completely pristine and disease-free.
It's wild. It's like taking a completely healthy, disease-resistant plant, moving it to a toxic garden, and suddenly it catches the local blight.
Yeah, it's incredible.
But if LS is an autoimmune disease driven by circulating antibodies in the bloodstream, those antibodies were hitting both her leg and her vulva the entire time.
Right. And this raises an important question regarding tissue positional information. Why did the circulating autoantibodies only attack the thigh cells after they were transplanted?
Right. Why then?
It strongly suggests that the localized environment dictates the immune response. This could be driven by the highly specific local microbiome of the vulva, chronic microexposure to urine, or even localized nerve ending signaling.
So it's something specific to that zip code.
Exactly. Or, alternatively, researchers theorize that fibroblasts possess an inherent geographic memory regulated by things like HOX genes that literally tells a cell where it lives in the body. So once the thigh skin was placed in the vulvar geography, it eventually succumbed to the localized environmental triggers, effectively adopting the disease profile of its new home.
And the environmental triggers in that specific zip code don't just cause a fascinating biological quirk. They fundamentally alter how a person's body functions on a daily basis.
Absolutely.
Let's look at the functional impact detailed in the NHS and BSS-VD sources. When the architecture of the labia minora and majora fuses, it structurally blocks and diverts the urinary stream.
Patients report urine spraying, dribbling, or physically pooling behind the fused tissue.
And the functional disruption extends heavily into intimacy and sexual health. Dyspareunia, or severe pain during penetrative sex, is a major hallmark of advanced LS.
Because the introital narrowing and the rigidity of the fused scar tissue mean that any penetration causes immediate painful tearing of the mucosa.
Which, as we established earlier, simply restarts the fibroblast-driven scarring loop, compounding the fusion.
It's a vicious cycle.
And the literature emphasizes the psychological fallout from this. We're looking at extreme mental distress, high rates of clinical anxiety and depression, and profound psychosexual dysfunction.
And hovering over all of this functional impairment is the long-term oncological risk.
The cancer risk, right?
Yeah.
But the lifetime risk of malignant transformation is relatively low, isn't it? The literature places it at under 5%.
It is under 5%, yes. But the chronic unmitigated inflammation can trigger cellular atypia. This presents as differentiated vulvar intraepithelial neoplasia, or DVN.
And DVN is a direct precursor lesion to squamous cell carcinoma.
Exactly. This is the primary reason why lifelong surveillance and adherence to treatment are strictly non-negotiable. The inflammation must be clinically suppressed to halt that progression toward dysplasia.
Okay, so given how fragile the tissue is, and knowing that physical stress causes tearing that feeds the scarring loop, I have a question. What does this mean for a patient going through major physiological events?
Like what?
Like childbirth. If the tissue is fused and narrowed, how does a patient navigate something as mechanically demanding as having a baby? It seems like it would be physically impossible without catastrophic damage.
It's a highly illogical assumption, but the clinical data actually provides a very reassuring counter-narrative here.
Really?
Yeah, the BASH guidelines confirm that pregnancy does not typically accelerate or worsen lichen sclerosus. Furthermore, the vast majority of patients with LS can safely undergo normal vaginal deliveries.
Wait, even with existing fusion and a high susceptibility to fissuring?
Yes. The immunology of pregnancy is actually fascinating. The maternal immune system naturally shifts its profile, moving away from cell-mediated immunity to humoral immunity, just to tolerate the fetus.
Okay.
And this systemic shift often temporarily suppresses autoimmune flares like LS.
That is incredible.
Now, there is a slightly elevated risk of perineal tearing, and an episiotomy might be used to safely manage the tissue expansion, but vaginal delivery is absolutely viable.
What's the catch?
The cornerstone of this success is that patients must strictly maintain their localized tissue health using potent topical steroids, which are clinically proven to be safe throughout gestation.
Okay, so if potent steroids can keep the tissue calm enough to withstand childbirth, how exactly does the medical field approach unfusing the anatomy when the damage is already done?
Well, the gold standard first-line defense across all international guidelines is ultra-potent topical corticosteroids.
Like clobetasol propionate, right?
Exactly. Clobetasol is the primary agent used. At a cellular level, it crosses the cell membrane and binds to glucocorticoid receptors, basically physically altering gene transcription to shut off the production of inflammatory cytokines.
It essentially gags the confused bodyguards.
Yep, and halts the destructive ECM1 degradation.
So the clobetasol stops the itch and halts the act of scarring. But for patients who already have early-stage fusion, the sources describe this technique of gentle manipulation.
Right. Patients apply a 5% lidocaine ointment, wait for the localized anesthesia to peak, and then gently apply bilateral traction to divide the newly formed adhesions.
Basically gently pulling it apart.
Exactly. And
Yeah.
then they immediately apply the clobetasol to prevent the fibroblasts from rebridging the gap.
Okay, so that works for early, pliable adhesions.
Hmm.
But when the fusion has matured into thick, rigid scar plates that cause significant functional impairment, like trapping urine or making intimacy impossible, surgery becomes necessary.
Yes. Surgeons will perform a division of adhesions to release the labia or the clitoral hood. They might also use a Fenton's procedure, which is a median perineotomy, to structurally widen the vaginal introitus.
Here's where it gets really interesting, though. Based on the underlying mechanics of LS, surgery creates a massive biological paradox.
It does.
Because a surgeon's scalpel inherently causes tissue trauma. And we just established that physical trauma in an LS environment triggers the exact localized healing cascade that causes fusion in the first place.
You are describing the Koebner phenomenon, or the Koebner response. It's a well-documented dermatological principle where physical trauma to the epidermis induces new lesions of the pre-existing skin disease right at the site of the injury.
So the surgical incision alerts the immune system, flooding the area with the very cytokines and fibroblasts that drive the pathological scarring.
Exactly. So the medical intervention designed to cut the fusion physically instructs the body to manufacture more fusion.
That is wild.
And if we connect this to the bigger picture, the Koebner response explains the astonishingly high failure rate of these procedures. Clinical literature demonstrates a 40 to 50% recurrence rate of anatomical fusion following surgery.
Wow, almost half.
Yeah. Surgery is never curative for lichen sclerosus. It is strictly a mechanical intervention aimed at restoring immediate function.
So how do they prevent the surgical site from just gluing right back together during the recovery period?
It requires a highly aggressive, deeply regimented postoperative protocol. To suppress that Koebner response, patients have to adhere to strict maintenance steroid therapy immediately following the procedure.
So the clobetasol has to go right on the wound.
Yes, applied to the surgical wound to continuously suppress the inflammatory healing cascade while the tissue heals. If the patient drops the steroid regimen, the fibroblasts will rapidly bridge the gap and the fusion will return, often thicker than before.
Okay, so to wrap up this deep dive for you,
Yeah.
yes, lichen sclerosus definitely causes labial fusion. It's a localized, autoimmune-driven inflammatory process that targets structural proteins, destroys tissue elasticity, and turns the body's own wound-healing mechanism into an aggressive scarring loop.
A loop that buries the delicate architecture of the vulva.
Exactly. And the paradox of treating it is that surgical trauma triggers the very disease you're trying to cut away. But the through line in all these guidelines is that with early detection, disciplined use of ultrapotent topical steroids, and proper clinical surveillance, the structural integrity of the tissue can be preserved.
Because the preservation of function and mitigating that oncological risk relies entirely on seeing past the initial symptoms and really understanding those underlying biological mechanics.
I want to toss this over to you for a final thought, though. Because looking at the broader science we've covered today, where does this leave us in terms of the future of treating conditions like this?
Well, it brings us right back to the positional information mystery from the thigh flap case study.
Oh, right. The geographic memory thing.
Yeah. If autoimmune dermatoses like LS are heavily dictated by local environmental triggers and the inherent geographic memory of the fibroblasts, meaning the tissue succumbs to the disease largely because of where it is located on the body, it shifts the entire therapeutic paradigm.
How so?
What if the future of medicine isn't about chronically suppressing the immune system with ultrapotent steroids at all?
Right.
What if, one day, we could utilize targeted gene therapy to simply reprogram the HOX genes and the geographic memory of those localized skin cells? Imagine being able to convince the cells of the vulva that they actually live on the thigh.
Oh.
We could effectively cure the localized disease state without ever touching the immune system simply by tricking the tissue's internal GPS.